I took a little bit of a different approach. I had some Parkinson's specific slides that I built out, and then I realized that I kind of needed to add a little more introduction about what I do. There's a lot of difficulty. The cancer space in general is filled with a lot of different specialists, and we are by far the smallest, probably the smallest of all medical specialties. So it's just, we are not people that a lot of other people know, and even other doctors don't know necessarily what we do. So I wanted to introduce myself on that, in terms of our specialty as a whole, and then we'll get into some more specifics on Parkinson's in particular. So I'll do a little personal introduction, radiation oncology pearls, meaning what our specialty entails, the tools we use to treat cancer, then radiotherapy for cancers and radiotherapy for non-cancers, and we'll include some Parkinson's specific info in there too. So I won't go too much into my introduction, just that I did my undergrad at Washington State University, go Cougs, and then Rutgers was my medical school, so I went across the country for that. Came back across the country, did a one-year transitional internship in Spokane, Washington, which is near my hometown, and then went across this country again, this time to the National Cancer Institute, and I trained there for my radiation oncology residency. Then I moved to my hometown again and joined a practice there, and then I left in 2021, came here, and started Oncology Nevada. So pretty excited here. We love Reno. It's been fantastic. So this is like a common comic that gets sort of circulated around in the medical space, the 12 medical specialty stereotypes. And so there's different things. One of my favorites, the neurosurgery one on the top right is like, come on people, let's get this patient in the room. Am I only a person who does any work around here? We have 6 more craniotomies scheduled for today. Come on guys, this isn't brain surgery, right? That's his favorite joke. Things like that. So ours is this one over on the right at the bottom, and it's just who are we? But nobody knows, right? We're a very small field. There's 350 million people in the United States, and there's about 100 radiation oncologists coming out of training every year. So it's not a big thing. Number of medical schools that require radiation oncology rotation? Not a single one. So what does this tell you? It tells you that, frankly, most other physicians know about as much about our specialty as the average non-medical person just walking on the streets. This isn't, primary care knows very little about it. Even other oncologists don't know a lot about what we do. But we are a subspecialty of oncology, so we are oncologists first. We are one of the 3 main oncology disciplines, so that's along with medical oncology and surgical oncology. So medical oncology does like the medications, chemotherapies, things like that. Surgical oncology obviously takes out tumors surgically. We are a direct pathway of training. A lot of people say I'm their radiologist, and I'm not a radiologist. Diagnostic radiology and radiation oncology split more than 50 years ago. So there's nobody in our specialty that goes through diagnostic training, diagnostic radiology training. We just go straight into radiation oncology, and we have 4 years of dedicated cancer training, which makes us the most training of any oncology specialty. We do diagnostic workups, we create treatment plans, we treat both pediatric and adults, we treat directly or we refer patients for treatment as needed, we manage symptoms, and we evaluate outcomes afterwards and provide follow-up care. Radiation is totally different from chemo. A lot of people get those two confused. Radiation is a targeted therapy. It goes right where we point it. It's like surgery. Chemo goes into the blood. It goes everywhere. Good thing is it doesn't miss anything. Bad thing is it doesn't miss anything. Radiation is totally different. It's targeted and precise, only going right where we point it and accurate down to a submillimeter. Again, we treat cancers as well as some benign diseases. I mentioned some. We're going to mention sialorrhea, of course. And then we use radiation a lot of the time to cure cancer on its own. Prostate cancer would be a classic one, but we also will sometimes use it as an adjunct to surgery or chemotherapy. It just depends on the type of cancer and the stage of cancer, things like that. And then we also use it not only, there's an external form of radiation, which is our most common tool, but we also do some internal forms. It's called brachytherapy. I'll talk a little bit about that. So this is kind of an overview of our overview of what we offer at our clinic. So we treat all cancers and suspected cancers, meaning, again, a lot of the patients that come to us, we don't necessarily know what they have yet, and we have to figure it out through scans, biopsies, things like that. So we also will see a lot of patients before they've ever been diagnosed with cancer, and sometimes they don't have cancer, and so we're seeing them doing a workup, and it turns out it's not cancer. Those are the best calls to make, but they're in the right place if it is cancer, and we can start to take care of them from there. Benign diseases, again, Dupuytren's contracture, plantar fasciitis, arthritis, bursitis, and then kind of towards the bottom, sialorrhea I have in there too, and I have some information on that. This is our main tool we use for radiation. It's called a linear accelerator. We don't use radioactive stones very much in our field anymore. That's what everybody asks, is what kind of source are you using? It's not a source. It's a electrically generated radiation. So just straight from the municipal power supply, you plug in this machine, and then it accelerates electrons. Either use those directly to treat some conditions, or it's created. We turn them into photons or X-rays to treat things that are deeper. This is sort of the general of what this machine entails. It's a lot more complicated, but the big thing to know is that if you get close to this machine and it's not on, you will not get any radiation. That's no problem. It's only giving radiation, emitting radiation, when the machine is turned on and targeting what we're trying to do there. So this is a totally safe machine. We wear dosimetry badges in our clinic. We never get any reading because we're not in the room as the patient's being treated. This is the big thing about this machine, is that it has something in the head of the machine. It's called a multi-leaf collimator. It was put in 10, 15 years ago, and it's basically individually motorized lead leaves that come in and shape the beam exactly to the target that we're trying to create. Cancers are not shapes like uniform shapes. They're usually jagged. They're bigger on some side than the other. It's not like you're treating a sphere or a box or something like that. You're treating things that are very oblong in shape, and they're going to be looking different from every single viewing angle. So you have to adjust the beam every angle that you shoot the radiation through. This is kind of one of those picture tells 1,000 words. Long story short, the one on the left is what we used to do. The one on the right is pretty much what we universally do now. We used to have to treat big boxes around everything to treat our targets, so we didn't miss. Now we figured out how to create these very elegant plans that carefully treat the areas we need, but not the areas we don't need. We have a tool called stereotactic radiosurgery or single fraction radiation, and it's just just one treatment that we do for patients. Classic would be brain tumors. We use it in a few other indications as well. There's another one called SBRT or SABR. They literally changed the name from SBRT to SABR so they could call it SABR, and it sounds cooler. So that's the reason they did it. But it's the same exact thing. It's just a few treatments. Classic would be for lung cancer. This was very hard to get right. In comparison to stereotactic radiosurgery, which is just a one fraction treatment, that one can be done in the head pretty easily, because if you mobilize the head, things are not moving around a whole lot in there, so you don't have to worry about missing. However, take the example of a lung cancer. If somebody has a lung cancer, as they're breathing in and out, that lung is expanding and collapsing and moving the tumor with it. So we have to have tracking devices in order to carefully treat the tumor and not treat the things around it to an excess dose. And we're giving whopping doses in each time when we're doing the stereotactic treatments, so it's very carefully planned and executed. There was, I'm not going to go into that. Okay, so brachytherapy, this is the internal form of radiation. It's from a Greek word meaning short distance. This is where you put radioactive sources in or near a tumor. These are actually radioactive metals or stones or things like that that are going to go in or near a tumor for a period of time. Classic would be prostate, skin. We also use it for gynecological malignancies and occasionally breast. There's the ones called low dose rate, which are permanent implants. You've probably heard of prostate seed implants if you've been treated for prostate cancer or just read about it. These are small radioactive sources about the size of a grain of rice. They're implanted in the prostate and they stay there forever. After a few months, they've given off all their radiation and they become inert metal particles and kind of stay in place forever as that. There's another one called high dose rate brachytherapy, which we're putting a large, it's about in this machine, it's called an afterloader. There's a small radioactive source about the size of a grain of rice, but it's about 1,000 times more powerful than those smaller ones we just looked at. This one will not be permanently put into the patient. You just have it programmed to it's welded onto the end of a wire in that device, and you program the machine to deliver to extend the wire out with the source on the end into different devices you place in order to treat tumors. So. Another thing we do for prostate cancer that's been pretty exciting in the last few years is a gel. We use SpaceOAR. There's others out there, but basically what it is that longstanding issues have been when we treat the prostate with radiation. We are sitting right next to the rectum, and so the rectum gets some dose. Used to be pretty catastrophic for people, especially when we can only do boxes around things. Now we're a lot more careful with it, but you still get some dose to the front part of the rectum because it's touching the prostate. Well, now we can inject a gel between the two, separate them, and now we can treat the prostate without treating the rectum. Drops the dose by 90% to the rectum, and so we really don't see severe complications, rectal toxicities anymore the way we used to. It's done in a one injection, and it takes 3 minutes, and it stays in place long enough for us to get all the radiation in. Just real quick, that I think this is fascinating. Just shows how our field has changed so much. We used to just kind of consider cancers as being localized or metastatic. We don't any longer. We actually have found a middle ground. So the idea is that if something's localized, you could cure it. If it's just right where it started, then you can take it out surgically or do radiation and you could cure the patient. Now we found out that there's, if it was metastatic, if it was outside of where it started, no matter how limited it was, that there was no reason to treat the primary site of the tumor because the cancer was already spread, and they would say, quote unquote, the horse is out of the barn. It doesn't make sense to treat the primary site anymore. Then we found out that as things got a lot better in our field, different systemic therapies came out, better radiation, better imaging. All these things added up to a subcategory of cancers that's called oligometastatic. This is small volume metastasis. So if somebody has cancer that has only spread to a limited number of sites, usually defined as 5 or fewer, that we can actually cure these patients. And so it's pretty exciting, and we're seeing it more and more. Seems to be starting to get into even more widespread disease than just five metastatic sites. And so we'll treat these patients often with curative intent where we didn't used to. A lot of studies on this showing huge survival benefits to treating not only where it started, but also where it spread. So, what you came for? Rates of cancer and Parkinson's disease. This is one that I looked up. There was actually a lot more than I thought. Melanoma, these are the ones that are mainly seen as higher risk. Melanoma, brain tumors, thyroid cancer, breast cancer, kidney cancer, and uterine cancer all have a statistical increase in Parkinson's patients compared to the general population. Why that is, a lot of people don't know. There's no real obvious reason for that. Some of it is thought to be that, for instance, thyroid cancer, kidney cancer, those two in particular are often caught incidentally, and so if somebody has Parkinson's, they're probably going to their doctor more often and getting more scans, and so they're getting these things found incidentally. But that doesn't explain, a lot of these others like brain tumors and things, although I guess if you're getting scans of your head, that might be too. Uterine cancer almost never caught incidentally, so can't explain that one either. But these are things that that obviously are at a higher risk, that patients with Parkinson's are at a higher risk of developing. The big thing is, we don't treat them differently, although there are some specific considerations in the Parkinson's patients. So one thing that's really important is that just get your age-specific screenings for cancer. It's not different for Parkinson's. There's no subcategory of different screenings for them, but just to go over the screenings, because a lot of people don't know this, the big one is women between the ages of 25 to 39. Cervical cancer screening is indicated. There's different ways to do it, but in general, it's a pap smear and an HPV test. And then in that 40 to 49 range, you're looking at starting to get into cervical cancer screening, breast cancer screening, colorectal. They just moved that up to 40 years old to start screening. And that's usually colonoscopy. If the colonoscopy is negative, then you only have to do it once every 10 years. So it's not too bad, but it's that's a very effective screening method, and highly recommend you get it. And then prostate cancer screening is probably the easiest one. It's just a blood test. So you do it once every year or so, and then you just track the trend. And that's also a very curable one if people are getting their PSAs on time. And then 50 plus cervical cancer starts to go away if they haven't had if they've had a bunch of negatives up till then. Breast cancer screening, colorectal screening, prostate screening. And then lung cancer screening is a newer one, but it's for patients that have had at least a 30-pack year history of smoking. So that's the number of packs per day times the number of years they've smoked. So if they've smoked for a pack a day for 15 years, that's 15 pack years. If it's 2 packs a day for 15 years, it's 30 pack years. They have to add up to 30 pack years, and they have to have either be a current smoker or having quit in the last 15 years. If they've quit 20 years ago, they won't qualify for the screening. But that's the high-risk category that patients will get an annual CAT scan. And that has the potential to greatly improve outcomes in lung cancer, because our number one problem with that one is about 75% of patients are found in stage 3 and stage 4, which is obviously very difficult to treat, much less cure. So the earlier the cancer is diagnosed, the more curable it is. Sort of obvious, but also this is how our screening helps. This one's kind of funny. So this girl on the right that's in this, I was looking for some stock photos of a machine, and anyway, I used to work with her. Her name's Anita. She's fantastic. So it's just kind of funny that I just randomly found it as the stock photo online. But consideration of radiation therapy in the Parkinson's patients. This can be tricky for a number of reasons. So understand, with radiation, most of the time we're treating over, when it's cancer, we're treating a patient daily over a period of weeks. And so if that's the case, it gets tricky if somebody has a tremor and things like that, because we have to set them up every day. We want them not to move. We step out of the room, do a scan and all this stuff, and then we can treat them. And so it's tough if somebody comes in with certain, tremor would be a specific reason that it makes it a little tricky. So what we have installed are these tracking devices on the ceiling. And so, outside of this machine on the ceiling, there's actually triangulated lasers that track the patient's movement, and it will specifically shut the beam off in cases of tremor. So if somebody moves, fidgets, even coughs, anything like that, we're on the table and it throws if our tracking is out of alignment, it'll just shut the machine off at the speed of light. So even though a tremor seems like, hey, that's happening pretty continuously, most of the time the patient's tumor is in the right position to be treated. It's just when the tremor's happening that it's not. Well, at the speed of light, if you could just turn it on and off, it's no big deal. It might take a little longer to treat, but you're only getting radiation for about 1 or 2 minutes of the time they're in the building every day. So if it ends up being twice that, it's still not too bad. So that's probably the biggest thing that we've put in to help with these kinds of tremors and motion management as we're going through it. We also have other immobilization devices, masks, headrests, all these things that will hold the patient as still as we can, that will help make sure we're accurately treating the target every day. So take the next steps for your health. Big thing is be aware of your and your family's health history. Ask your doctor about cancer screenings, reporting new symptoms to your primary care doctor, and then practice healthy habits. Stay active and if able, exercise. Smoking, alcohol, just be moderate with them, obviously. Smoking, never a good thing. Alcohol, arguably, depends on the type. Some people say wine is good for you. I don't necessarily prescribe to that, but it's still, just be everything in moderation. And then sunscreen's a big one because melanoma, the #1 risk factor for that is sun exposure. So in terms of non-cancers, I'm just going to go through these real quick, and I'm going to end on the sialorrhea one. So we do treat some non-cancerous conditions with radiation therapy. This isn't a foreign concept. They've been using chemotherapy to treat non-cancers for decades, skin diseases, autoimmune diseases, anemias, things like that, different blood disorders that are benign. Similarly, radiation, I guess I moved sialorrhea up, perfect. So similarly, radiation can be applied to some non-cancerous conditions, because radiation doesn't work on cancer because it's called cancer. It works on cancer because certain aspects of the disease that other non-cancerous conditions do also express and exhibit. So sialorrhea, this one's really interesting because usually we treat a lot of head and neck cancers in my clinic, and when you're treating head and neck cancers, you're literally doing everything you can to spare the salivary glands from seeing radiation, because at the doses we're giving for cancer, the patients will, if the salivary glands are treated too much, they will have chronic dry mouth for probably the rest of their life, at least for a long period of time. And so so that's what we're always trying to do, and we're using these carefully painted plans to accomplish that. Well, if your problem is exactly the opposite, and your issue is the drooling, excessive salivation, as is common with Parkinson's, ALS, things like that, we can turn this around and we can just give a low dose to the salivary glands. And this is covered by insurance, has a lot of data behind it. Probably the most meaningful data are actually the patient-reported symptomatic outcomes. So they went to the patients afterwards, they said, how much has this helped your life? 80 to 95% say that this has been fantastic for them. And all it takes is 1 to 4 treatments that are applied to some of the salivary glands. Some studies, they treat all of the salivary glands. Some just treat the parotids. But either way, we're not treating all of them. We're only treating a few of them, and we're giving them a very low dose. They will recover from the radiation. Your salivary production won't be gone forever, but it's stunned for a period of time, usually several years, and then you can come back and get it again if you need to. So again, covered by insurance, very short courses. Again, 1 to 4 treatments, not sometimes weeks and months that patients have to come in for their cancer treatment. So it would just be 20 minutes for 1 to 4 days, and we take care of this. So it's a great treatment, highly underutilized. We do several a year, but we could certainly we can offer this to as many as need it. A few other things that we treat: plantar fasciitis. There's a randomized trial between steroid injections and low-dose X-ray therapy. A lot of these inflammatory conditions, people ask how radiation works for inflammatory conditions. Great question. So the reason it works, so these, what we found over, we've been using radiation to treat cancer for 100 years. And what we have found, the most sensitive cancers to radiation are leukemias and lymphomas. These are cancers of white blood cells. White blood cells are exactly what cause inflammation. So, and in fact, when somebody gets a steroid injection, that's what they're doing. They're just injecting this steroid in there to kill the white blood cells in the area. Well, this radiation is like the ultimate steroid injection. We just treat the areas of inflammation, the white blood cells in that area, nowhere else in the body, just right there where the inflammation is happening. They get wiped out, and these conditions greatly improve. So there was a randomized trial between steroid injections and X-ray therapy, and the X-rays worked better and lasted longer. Pain relief lasted an average of 72 months, and this is twice a week for 3 weeks. This is 6 treatments, and it's completely painless. They don't hear it, see it, smell it, feel it, taste it. They'd have no idea they're getting treatment if we hadn't told them. There's no skin reaction. There's no side effects of any kind, and the patients, and it works in the vast majority of patients, 85% with an average duration of response 72 months. Dupuytren's contracture, a lot of people have this, have no idea they have it. You've probably seen the John Elway commercials where he's got his fingers curled into his palm. Most common hand disease in the world. That also can be related. There's a foot condition, similar, actually same disease process, but on the foot. And this leads to a characteristic series of changes where somebody has a nodule on their hand. Over time, it grows into a cord, and over time, that cord contracts the fingers in the palm. This isn't trigger finger. People may have had trigger finger before. That one, trigger finger, you can like force the hand open, and it hurts, but you can snap it open. This one, you can try and open those fingers as much as you want. You can crank on them. You cannot get those hands open. They have this growth of the collagen there that is just entirely too stiff and strong. I mean, that is what gives most of our tensile strength to our soft tissues is collagen. So it is impossible to open that up. You have to do surgery once it gets that far advanced. But in the earliest stages, you can treat it and prevent it from ever progressing. So what we want to see is patients when they have nodules and cords or just very minimally contracted, you can treat this with a low dose of what we call electron therapy. It's a very superficially penetrating dose of radiation, kind of like what we use for skin cancer. Extremely low dose. The only side effect known is dry skin. We do hundreds of these every year. This is a very, very common treatment now, and it's been done in Europe even longer. And then it's just a quick mapping and a treatment. This is a before and after of a Letterhose patient. This is a plantar fibromatosis patient, seeing how tremendous effect the radiation had on this patient. Bursitis we can treat similarly. Arthritis we can treat similarly, both rheumatoid arthritis and osteoarthritis. We can also treat keloids and hypertrophic scars with radiation, and this is a before and after of a patient of mine. Here's another one. You can see that it really does work quite well for these overgrowth tissues. This is in essence a benign tumor. That's why it works. Radiation works on benign tumors and malignant tumors, both. Graves' orbitopathy, you may have seen people that have their eyes protruding like this. Is because the thyroid, the extraocular muscles of the eye get filled up with these thyroid proteins, and they force the eyeball forward. People lose their vision. It hurts a lot. Just a low dose of radiation to the back of the eye has a fantastic response for these patients. Again, covered by insurance. Everything I've talked about is covered by insurance. So that's my talk. Just leave you with my favorite slide. This is our specialty in a nutshell, radiation oncology. The top left is like what doctors think I do. I think I'm the Ghostbusters. What patients think I do, they think I'm the Emperor from Star Wars. What society thinks I do, they think I count my money. What my friends think I do, Einstein. What I think I do, I think I'm a ninja, but at the end of the day, I type. That's what I really do.